Good morning, everybody. Welcome to the morning session entitled Political Update. It may sound a little dry, and the hope is that it isn't. The idea is to talk about issues that are pertaining predominantly to spinal surgery in the UK, and we've got three of our hardworking colleagues to update us. We've got Stuart Blagg, Mike Hutton and David Cumming. So David's going to speak first in his role as CRG Chair and give us an update on the situation on commissioning and all things NHS England, followed by Mike Hutton, who you will know has been the GIRFT lead for spine, and he's going to give us an update on where we are with GIRFT and second visits, etc. And then Stuart Blagg will follow up, and his role in particular in today's conversation is around ODEP and beyond compliance and how we're going to use the BSR in conjunction with that moving forwards. The plan is to run all three talks one after the other to give a good block for time for questions at the end. As you know, please send through chats questions as we go, and Ashley and I will moderate that towards the end. So with no further ado, we'll start with David's talk. Thank you.
Hi, my name's David Cumming. I'm the Spinal Services CRG Clinical Chair, and I'm here to give you an update with regards to what the CRG has been doing, a bit about the CRG and what we're hoping to do in the future. So just to give you an outline, the Spinal Services CRG is a group which brings together clinicians who work together for the best interests of spinal surgery and spinal cord injury. We meet 4 times a year officially, but have communication regularly throughout the year. And there are representation from different clinicians from spinal surgery as well as spinal cord injury. And the spinal surgical representation is across specialised and non-specialised hospitals. And also the group includes patient representatives, national commissioners, public health representation, and members from the specialist societies, including the British Association of Spine Surgeons. This year's work has obviously been affected by the coronavirus pandemic, but work has continued to develop and maintain good practice during these challenging times. This is each year we create a work plan. The Spinal Services CRG is designated under D03. And there was 4 main parts to what we were wanting to do during the 2020 and 2021 year. So we wanted to look at measuring and improving quality. So the CRG was looking to support the development of the Spinal Cord Injury National Network, to oversee improvements in access and outcomes in line with the Spinal Cord Injury Service Review, which has been taking place over the last few years. We're also looking to develop regional spinal networks from a spinal surgical point of view, and work continues with regards to this, and I will discuss this in a little bit. We want to improve value and reduce variation across spinal cord injury and across spinal surgery. So for the spinal cord injury, we're setting up a clinical work streams to define national standards of care, and then developing a database to audit these standards of care and look to improve care overall. We look to support identification of new improving value proposals to support regional commissioners. And we are looking to implement spinal regional clinical networks and regional MDT meetings to reduce variation in practice. And we're particularly looking at low volume procedures where there is a high variation in practice, also a high morbidity and mortality, and we would look to make sure that these are discussed at a regional level. We are looking at effective commissioning, so the CRG would support the introduction of a best practice tariff, which was actually introduced last year, but we would like to continue this and continue to support the British Spine Registry in order to facilitate analysis of good practice. We are supporting the service review and developing new models of care for complex spinal surgery, and we've revised the service specification, and the new service specification should be released this year. And also we're supporting transformation across the CRG, so this is about supporting the implementation of the GIRFT recommendations, to reduce variation in practice and improve access for all spinal surgery patients, and the implementation of spinal cord injury national standards and change of outreach model into a more comprehensive model across England to support all patients from time of injury to long-term care. So first of all, to look at spinal cord injury, we're looking to, we've now set up a National Clinical Network Board, which has got representation from all spinal cord injury centres, patient representation and regional commissioners. We're working on developing standardised pathways across the spinal cord injury centres, and we have meetings every 2 weeks with clinicians across all the centres to look at creating one pathway to help patients from time of injury in the acute centre to transfer to a spinal cord injury centre and then their long-term care. Alongside this, we've developed auditable standards of care for pathway and clinical outcomes, which we will then be able to compare patient pathways across the country. We want to develop and improve the national database, which has been in place for some time. We want to continue to work with this, but to develop better ways of accessing it and better ways of getting data to look at different outcomes. And we want, and we're looking at discussion around improving the electronic referral system to the spinal cord injury centres so that we have a two-way referral system between acute centres and spinal cord injury centres. So we have invested in this area. So we've, in 2019-2020, £3.1 million has been invested across spinal cord injury centres and across spinal cord injury across the regions. We're looking to invest £6.2 million, which will be recurrent funding for spinal cord injury care across England. This money will be across all regions. It's been divided on a population basis to each region, and we're working up plans with every regional commissioner and supporting them from a national level to invest in the hub and partner model, where we will embed good practice from acute centres into spinal cord injury centres, and then looking at long-term care and long-term follow-up, as well as step-down beds when appropriate. So we wanted to improve education with regards to the care of spinal cord injury patients, improve care in acute centres whilst awaiting transfer, and for those patients who are not transferred, and invest in spinal cord injury centres themselves to improve patient care and standardised care across the pathway. So this is the network model which we're talking about. So at the centre of this, we have a National Spinal Cord Injury Network Board, which has representation from each centre and from each region. And this is to make sure that we create standards of care which are consistent, reduce variation in practice, improve efficiency, and improve training and innovation and adoption of best practice. The Spinal Cord Injury Centre will deliver the core SCI services, including inpatient, outpatient, and outreach services, but they will work with the acute centres to ensure that good care is provided across the service. The Spinal Surgery Centre and major trauma centres will be invested in with regards to support staff who are either coming from the Spinal Cord Injury Centre or linked in with the Spinal Cord Injury Centre. They will provide care for patients whilst they're awaiting transfer. They can be involved in follow-up, more local follow-up if that's appropriate, and will help with the SCI centres and work hand in hand with them. And we're looking at lifelong care with also involving the charities and the third sector to ensure that they're embedded in the practices as well. We're also looking at SCI teams to provide care for patients waiting for SCI beds, so to be including looking at specialist nurses, physiotherapists, and case managers across the system to support these patients, to support the discharge and follow-up process. And within this, we should also look at regional spinal surgical networks with the SCI services working hand in hand with surgical practices. So we're going through a process where the strategy group has approved in principle the investment. It's been signed off by the Programme of Care and the CRG. This conversation has been had at a national level with each region to make sure that regional models are worked up for the population and make sure that every region and every population has equal access and then we'll be allocating the funding moving forwards. So moving on to spinal surgery. Spinal networks have been a key part of this, and we're looking to invest in spinal networks across England. At the moment, we identified 14 spinal networks, and they're all at different stages. Funding was previously supplied through Sequence. However, we realised that did not always get to where it should get to with regards to funding the networks. So now we're trying to make this a cleaner process, and there'll be funding directly available. Networks need to be developed to improve collaborative working across the regions, especially at this time with COVID. We need to look at the demand and look at whether we can, each region and each hospital can help each other out. We need to look at improving elective and emergency care and pathways and make sure we have standardised pathways across each region. We've been working with GIRFT to make sure we develop improved pathways across each network. And myself and Mike Hutton have been working very closely, particularly around London at the present time. GIRFT have worked hard to make sure that there's a spinal dashboard available in Model Hospital, which can be accessible by anybody working within the NHS. And moving forward, we will be looking at more ICS funding and looking at how that can be utilised and how that will be working in the new funding models. So we've also been working on a new specification. This has now been developed. It has been shared with the spinal societies and it's been agreed, and it's just awaiting final sign-off within NHS England. The specialised centres, as they are now, have not changed, and the list of providers will be remaining the same at this time. The procedures are the same as well, as per the previous specification. The specification supports development of spinal networks, the use of data, particularly British Spine Registry for outcome data, and the elective pathways as per the NICE recommendations. And the resource at the bottom here on the link is to the NICE guidance with regards to low back and radicular pain pathway. A word on vertebral body tethering, as this has been an area which has come up regularly. So the CRG is working particularly with the help of Vinay Jasani to develop a study proposal, which will be submitted to the NIHR in the near future. Vertebral body tethering at this time is not routinely commissioned by NHS England, and we feel the best way forward that we've been advised is to take this through an NIHR proposal, and this is what we're doing. And this is the link to the vertebral body tethering policy proposition, where it was not routinely commissioned by the NHS at this time. Thank you very much.
Good morning. I've been asked to give you an update on the Getting It Right First Time programme, what we've been up to over the last couple of years, where I think things are heading, and what I can signpost you to and give you an insight into what's due to come out from the programme over the ensuing months. So we'd always intended to revisit trusts after our first round of visits, and we had updated the data packs, the data being updated to April 2019. And unfortunately, COVID hit us, and so we were unable to undertake those revisits. We voluntarily restarted visits after the first wave, and we've now revisited 25 trusts. If you wish to see your GIRF report, you just need to go to this website, www.future.nhs.uk, where you can find your trust reports, along with observation notes and also implementation plans for your trust and spinal surgery and pain services. And I have to say, in those 25 visits, they've been a joy, really, because things really have improved. I'll give you a couple of examples of this, given the time constraints. But if you recall this graph, this was displayed this in 2016 BritSpine, one of the first ever GIRF data analyses. And it was patients who had had 3 or more facet joint injections, stroke medial branch blocks injections within a 12-month time frame. And look at the variation above that red line, which is 3 standard deviations from the mean. Skip on to 2019, and you can see that variation is reduced. The English average is reduced, and there's far fewer injections going on. BSR and the effect of the best practice tariff. And when we first started, we had about 10% of NHS spinal surgery hitting the BSR. And in this graph, you can see the activities by region towards the end of 1920 in the best practice tariff. And about 50% of NHS spinal surgery is now hitting the BSR and NHS trusts. And there's a similar picture in the independent sector in as far as a real improvement in terms of what we're recording. And now I think we need to move into the next phase of starting to drive, making sure our patients have got patient outcomes recorded so that we can actually drive better outcomes for our patients by being able to reflect on what works and what doesn't work for them. So if you want a GIRF revisit, do please contact us. This is my project manager's email address. We're happy to do so. It's a lot easier setting up now in one of the few advantages of COVID, which is Teams and Zoom conferences. The attendance have been outstanding in all those revisits, and I thank all of those who've attended during these difficult times. So during 2019 and the early parts of 2020, we also visited about 64 independent sector sites, all the Spire Healthcare, Nuffield Health and the Horder Centre. Again, with the similar data packs to those that were reported at NHS Trust, but they did also include FIN data. There was a set of recommendations made for each provider, and the whole thing was really well received, such that I think Circle Stroke, now what used to be BMI, are going to start visits in July 2021. And if I can say in a simplistic way, there's a report coming out, should be out in the next couple of months, on this independent sector pilot. But I would suggest that the situation is very similar in the independent sector compared to the NHS, which is a lot of variation, some of it understandable, some of it good, some of it bad across the independent sector. If you look, that's that facet joint graph showing you again, with the green and yellow dots being independent sector sites. So what with the wave that we are now faced, and the mounted effect that we're faced of COVID, this is the waiting times across all treatment functions. And we can see what that has done to our 52-week waiters. It wasn't great beforehand, but boy, oh boy, have we got a problem now. And the biggest, worst problem is in trauma and orthopedics, and neurosurgery follows a similar pattern. And I suspect in neurosurgery and trauma orthopedics, where our spinal data sits at the moment in these sort of things, spines is a significant component to that problem. So the London Regional Director recognised that this was an issue and asked GIRF to try and help out with restoration of services, along with the NHS Restoration Recovery Plan. And in a number of specialties, spine's one, we've engaged with what were integrated care sectors and systems. And I led the discussion very strongly that we should actually do it along the lines of London spinal networks in the case of spinal surgery, because they don't necessarily cross-correlate. So we got together as a group and we set out a group of local clinical expert panel, which involved everyone from a PAN pathway perspective, and came up with some best practice pathways. Now, none of this is completely new, it's just slightly updated from where we've been in other pathways. And to support that, we have regular updated data, not with a 1 or 2 year lag, but now with a 1 or 2 month lag. And we've got benchmarking, trying to use our top 10% performance at the end of 2019 as our standard. To support this, we've got an academy of sharing good practice that is online on the GIRF website and is just about to start being populated with good examples from spines. So that spinal program has looked at come up with some simple priorities, and we're really going for back, neck and radicular pain pathways to start with. Why pathways? Well, I'm a big believer of them. I think they help with the flow of patients, and it means that we can get patients in front of the right clinician at the right time for their condition. And the data supports them, which is that if you follow the national back and radicular pain pathway, then you end up with patients having fewer unnecessary injections. So we've come up with 5 sets of pathways for the commonest conditions. Here's one, and you will see that this is a PAN pathway from first presentation to discharge on one slide, what is expected that's to try to standardise for patients in London. And you can see that at the front, central to all of this is a virtual triage review, where there is a triage and treat practitioner, who represents the interface service, with a spine surgeon and a pain specialist, all deciding what the right route for that patient is. If a surgical opinion is agreed, then that patient follows this pathway through where it's all standardized, and then we have a target discharge date with their discharge plan. And you will see it incorporates the virtual review of patients. So to support this, we've sent out to the networks their data with as it stands at the end of 2019, pre-COVID. And what's great is, I've mentioned this earlier, is that we now are going to have, this is preview mode, so it's not gone live yet, our data in real time. So if you go onto the Model Hospital website in a couple of weeks, you should be able to go in, have a look under your trust values and see all the other trusts, how they benchmark against you, okay, on some of these metrics, these gateway metrics. And there's lots of them, and there'll be explanations to what they mean, etc. But you can go into that little tab and see the finer detail of what the numerator and denominator and what drove that metric. And you can actually hover over things and see where your trust is performing. Okay, and then more importantly, you can click on that bar and it will bring up a chart of where you sit compared to everybody else, and hover over those lines and establish who they are and change the way in which you view the data so it might be more meaningful. It'll land on what we think the most meaningful way of doing things is. So why bother? Well, this is day case discectomy, and I think it's a good thing to do. I certainly learned awful lot about it in the first round of visits. There's variation, trusts are doing it, and I think even more now in the COVID era, we need to move over to day case discectomy. And why is it that this trust does it? It's specialist, other trusts don't do it. Well, that's the example I'm talking about of the data driving us to request that trust to give us its day case discectomy pamphlets, governance, structures, etc., so that we can share them with anybody else, so we don't have to start reinventing the wheel. These are patients who are emergency admissions with a length of stay over 4 days. And it's interesting, how is this trust able to get their patients out quicker than other trusts in London? So it's those discussions. It's not saying this data is the be all and end all, but it starts a discussion so that in a positive way, so that we can try and get things shifting. So on to a few other things. In April this year, the Learning from Litigation Claims will be published. It's a report. We also visited best performing and more challenged trusts in terms of spinal litigation and orthopedic litigation, to allow us to try and find out, work out if there's common themes related to litigation claims. Not so much just in terms of spinal surgery, but also the processes behind claims management within NHS trusts, which I have to say were very variable. This has been done in conjunction with NHS Resolution. And in conjunction with that report coming out, you will each receive an update for your litigation data, and it will identify for you which patients have had litigation cases, so you can see whether it relates specifically to your service or another part of a patient undergoing spinal intervention in your trust. And we ask that you reflect upon it and see if there's any areas of improvement. And lastly, on to the medical devices safety program. GIRFT has been put front and center of this in terms of trying to look at, after the Cumberland's report, First Do No Harm, which I think would have had a lot more press coverage had it not been for COVID. It has been tasked with trying to, across all specialties, not just spines and orthopedics and things that have been through the GIRFT review, come up with a mechanism to actually improve medical device safety, ensuring that patients can have the best and safest medical device, and allowing us to act upon things if we feel that things are failing. Now, it's quite clear that in that setup, there are world standard and internationally recognized ways of doing this. And in the British Orthopaedic Association for Orthopaedics, there's been the Orthopaedic Data Evaluation Panel, and also Beyond Compliance. Beyond Compliance looks at new and innovative implants. They are tracked very, very closely with data so that we can see whether things are working really well or not going so well. ODEP evaluates what's going on already. Now, I'm not going to talk any more about that, but that is going to be the centerpiece that we're going to already have started to look into. And we've also set up a committee. So on that note, over to Stuart, and I'll answer questions at the very end.
Good morning. Thanks for the opportunity to talk to you about ODEP and beyond compliance, and how it's going to be very, very relevant to us in the spinal community. A bit about ODEP first. The Orthopaedic Data Evaluation Panel. Don't get put off by the orthopaedic. This is going to be just as relevant to spines as anything else. It was set up in 2002 to provide information about the success of hip replacements because of a particularly bad problem with the capital hip. And it was noticed that we didn't have information about things we were implanting. That may ring a bell now. It's set up to include a panel of leading independent UK surgeons and non-clinical experts and reviews submissions from manufacturers to rate the implants. So far, it's managed to rate 700 implants. And of those, there's 100 which dropped their ratings and then were removed from market because the companies felt that they weren't implants they wanted to continue with. It rates implants after 3, 5, 7, and 10 years, and it gives them a number, a letter, and an optional star. Everybody likes a star. The number is how many years after surgery the device is rated. The letter denotes the strength of evidence. So the highest rating you can get is a 10 A star. To get this, the implants got to have been used on at least 500 patients, with 400 reaching 10 years, revision rate of less than 5%, not changed design in that time, had no reports of poor performance, and be used by 3 or more clinicians and clinics outside the co-developers. The next term is beyond compliance. And beyond compliance was brought in after the metal on metal hip problems. Some of you may be aware of this, but using a metal on metal bearing has been found in some cases to lead to disastrous failure. It's there to support a safe, stepwise introduction of new or modified implantable metal devices. And it's optional. It involves an independent panel of experts working with an implant manufacturer. It started in joint replacement, and again, we're now looking to implement this in spine surgery. The aim is you can protect patients from poor implants, but still support innovation, which is really important. So the main stone which ODEP and beyond compliance was built around is the National Joint Registry. The British Spine Registry has the same values, considerable data, and should form the basis of evaluation of our implants. There's some other big advantages. The NJR is moving towards PROMs and PREMs. The BSR was set up with these. So we, in a way, may end up having more data and more useful data than some of the existing registries. As with all things, we can look at how other people have done it and try and do better. Hospitals and surgeons around the world use the ODEP ratings. They use them to decide which devices to use and which to change to. And spine devices fail and vary in success. We all know that. And we know there's large numbers of new devices introduced all the time. We felt that spine surgeons would be better placed to make decisions on implants with this type of data available. And then came Cumberledge. Baroness Cumberledge was charged with writing a report predominantly because of various medical failures on implanted devices, especially the surgical mesh for female incontinence. This became high profile, and you're all going to be aware of what's played out in front of the media. The reality was that there was very little information being kept on these implanted devices. Patients were finding out that they couldn't find which device was used and what its long-term outcome was. Baroness Cumberledge stated that a database following the implants in patients should be legally mandated in the public interest, and it should hold data on patients, implants, surgeon, and healthcare provider. In the words of the report, to be mandated by the Secretary of State, as this mandate overrides the patient's rights to opt out of their personal data being shared, it's only reasonable that the data collected is at least necessary to fulfill the legitimate purpose. Keith Tucker and his team set up, first of all, the National Joint Registry, and then ODEP and Beyond Compliance for joints. And they've then reached out to other people implanting devices. Various other teams and groups have already joined in with this process, Shoulders being one of the groups. And with Sachin and Mike leading, we put together a group across all the surgical spinal teams and industry, and then worked with the previous ODEP and Beyond Compliance groups and Keith Tucker to try and get the best for spines out of this approach. I have to say, Keith Tucker and his team have been amazing. They've been so useful. So, is spine the same as joint replacement? Joint replacements move. They have to move. That's the definition of them. And by moving, they must wear. And therefore, a failure occurs in some patients. With that failure, revision. And measuring the time from putting a joint in to the time it fails is a very hard measurement. And that was the basis that a lot of the National Joint Registry and then ODEP and eventually Beyond Compliance used. And that time to failure is fine as long as your implant generally will fail at some stage. And our problem in spines is if we do a spinal fusion, if it's successful, there is a bony fusion and the construct won't fail. So how do we measure success? So for ODEP, we set up a group and we began to look at how we would, first of all, test the process. And that's the stage we're at. We decided that the easiest way to test it, to put together a system just to make sure it would work at all, was to use something that would work in a similar way to a joint replacement. And the group decided that the first thing that they would try and test this on would be a cervical disc replacement. The process for ODEP is, first of all, you have to establish a benchmark. What is reasonable? One uses literature. We've debated whether we use the ACDF. Is a fusion a reasonable benchmark for a disc replacement? Then we have to work out data collection. We have to work out a form, standardized data, what fields are going to be used, what the sources are. The data in the end has to come from industry, but industry has to be able to get it from somewhere. And the main source of this data we expect to be the British Spine Registry. So industry will then have to request a specific data set saying that they are going for an ODEP rating, and the British Spine Registry will export it. We then need to look at data analysis, statistics. We get bioengineers reports. And we then need to set up our criteria for the rating. We've got quite a way to go before we're going to put out our first rating. But we aim to rate all the implants, which is a massive task and is something that orthopedics and the Joint Registry has been trying to do for many years. On the other side of the coin, with cumberlage and the way that the press and the government now view surgical implants, I think we're going to have to do this. Beyond Compliance is looking at new introductions, and the Beyond Compliance group decided to look at vertebral body tethering. And again, they've set up a group, they're working with the manufacturer, they're looking at data collection, and typically for Beyond Compliance, the Joint Registry uses a 3-year data collection period. Often, with Beyond Compliance, one needs extra data. And this will involve the BSR, but possibly bringing in extra fields for the BSR. We then need to recruit surgeons, consent the patients, and also ensure that any explants are collected and reviewed by the accredited team. We need a regular review of data. Generally, it's reviewed every 6 months. This isn't mandated, but again, we can see through a lot of the legislation coming through with government and the direction of the Cumberledge report that this may well become mandated. And we aim to set out the gold standard for introduction of new spinal devices. This all relies on an enormous amount of work. If we look at the HIP team, they have a group of rapporteurs. These are unpaid experts. These are people who put their time in for free, but mostly they get the time back. And we're going to need spinal volunteers to get involved in all of these processes. But as always, quoting Mark Twain, the secret to getting ahead is getting started. So with Keith Tucker's help, and enormous help from a group of colleagues in the spine community and others, we're hopefully going to make a start. Thank you very much.
Okay, thank you very much to the three presenters. Not a lot of action on the chat, so we'll just go through the questions that we've got so far. The first talks about rehabilitation for cancer and infection, and that's come from Rajat Verma. We all know that spinal cord injury was set up for trauma, and that they do take quite a large number of patients who have non-traumatic spinal cord injuries, but still exclude patients largely who've got metastatic spinal cord compression and cord injuries. Any thoughts on that, David, in terms of where rehabilitation might be going for these patients?
Yeah, thanks, Ashley. I think Rajat's question and Joy's question are very similar. So there's a whole working group, and I'm actually working with Joy as part of that. So there's a clinical network now established for spinal cord injury, which has representation from all the SEI centres, has representation from neuro rehabilitation, and from commissioners as well. So we know that there are patients who are not suitable for an SEI centre because, for one reason or another, SEI centres are set up to deal with patients who can be rehabilitated, and actually it's worthwhile going to that centre. But what we do know is, as you say, there's a lot of patients in the acute sector who, one, need care before getting there, because there are not just the ones who will never get there, there's the acute trauma ones who actually may be on ITU or may need to be in that acute centre before going to an SEI centre. So the whole framework around the investment is to invest in in-reach and outreach. So historically there's been a sequence around outreach from SEI centres, but we're looking at every region now to sit down with their commissioners, with their major trauma centres, major spinal centres, their rehabilitation services, to map out what they need. So that will be some investment in acute sector. It's where there'll be nurses and physios who will be linked into the SEI centre to help look after these patients. I've also made an approach to people like Macmillan. We know that, for example, metastatic spinal cord compression, these patients probably should not go to an SEI centre. You don't want to be 200 miles away when actually you're undergoing cancer therapies, etc. So I'm going to work with Macmillan, with the charities, to try and improve care. So my vision is to make SEI care more, you can keep the specialist part for those people who definitely need to go to the SEI centre, which is a large chunk of them, but there should be a much wider knowledge about SEI and about how to manage people's bowel care, bladder care, and help look after these patients.
Thanks, David. You're on mute, Ash. There's a question from Chris Adams, and I think it's probably mainly to Stuart, but it may be worthwhile other people chipping in. So the question is what's the political view about us having to deal with implants inserted out with the UK? So to you, Stuart, first from a beyond compliance or ODEP question, but I think there's a wider question there in terms of commissioning of services, etc. Try again, Stuart. I've unmuted you. I think there's a problem with. I think you've stalled again.
Lee, do you want me to go from a commissioning point of view?
Yeah, please do. If there is a relevance there. Yeah.
So, I mean, it's an interesting area. So I frequently get letters from NHS England to me to say, this patient wishes to have this procedure done abroad, will we fund it, etc., or they've had this procedure done, can the NHS pay for it? Now, whether this will change with Brexit, I don't know, to be honest. But at the moment, if that procedure was to have been performed in the UK or in England, and we think it's a reasonable procedure which is commissioned by NHS England, then actually we are obliged to pay for that and continue the care of that patient. We do frequently challenge, things where we think actually we wouldn't do that. So there's an area such as upper cervical fusion for certain conditions, which are done in a couple of places around Europe, where I quite often ask for expert opinions in the UK or in England, and they would come back and say, we wouldn't actually normally fund that, so we will argue those cases.
Another question from Raja, again for Stuart, if you've, or maybe David. It's for beyond compliance and VBT. So who decides which surgeons take part? And I suppose an extension of that question is this going to be trial-led, as Vinay is proposing, or is this going to be beyond compliance as far as VBT is concerned?
So I think the directors.
I'm not sure if you can hear me, but I'm afraid I can hear nothing at the moment. So I can hear none of the chats.
So I'll answer. So from the point of view of the CRG, this has been an area where we struggled for a while, because we know that it's a very emotive area. We know there's children going abroad, crowdfunding, etc., and it is being done. We did do a clinical policy which said it was not for routine commissioning. We have looked at that again, and we've taken lots of advice. And the advice is that we should go to put in an NIHR request, and Vinny's quite far down the line with that. So when we get further down that line, and hopefully we get that approved, then it will go out to ask which centres want to be involved. And there'll be very strict criteria of who it should be done on. And so
I don't know if you can hear me. In answer to Chris Adams' question about implants inserted outside the UK, there's a fairly pragmatic view that we need to deal with the British public and what happens with them. So we will do our best. But obviously it's less than ideal, and one won't have all the information. And in the same way with the BSR, when one does take an implant out, one has the option of putting that into the BSR, whether the patient was already in it or not. And equally, the explant centres being set up by ODEP and Beyond Compliance will be usable for spinal implants, and we'd send the explant to that, and it would then be looked at further, and that would feed back in.
Thanks, Stuart. Sorry, David, there's obviously a slight time lag there, but it almost timed perfectly. A question for Mike, if I may. So Apinda Sahota has asked, with the ageing and increasingly comorbid population, how are you going to view that the networks and GIRF will work together with care of the elderly physicians in model services, like has worked, for example, in hip surgery?
So I think that's a really good question. I mean, I think that it all somewhat depends on what you've got already. I don't think we've ever actually looked at that. But in terms of a lot of the orthopaedic trusts have the geriatricians, or the care of the elderly physicians, as we call them, integral in looking after the spinal patients as well that come through with spinal conditions. So I don't know what the variation of that is around the country. It'd be very interesting to see what it is in orthopaedics, because I would imagine if in orthopaedics the spinal patients come in under there, we will actually be able to see it. But I'll take that forward. I think it's a good point.
Okay, next question is from Apajay Golash. how would you control surgeons using new implants introduced by industry? I suppose that's a question for David, given that Stuart's reloading, I think.
So I think there's various questions around. So if an implant is very similar to something that's already being utilised and used, then usually the industry will go through that line where it will fall under something that we're doing already. For example, a new pedicle screw, etc. There's nothing specifically different about it compared to the previous designs. If it's something completely new and it's a different procedure, then that's where it would need to come for commissioning agreements. There is always companies who try and get around it by saying we're going to they code a certain procedure, but it's a completely different procedure. And that they're the sort of things where it's something entirely new, where I think we need to develop beyond compliance and ODEP, and they should go through that route.
So I'm not sure if
we can hear you, Stuart, I think.
Brilliant. And I can now hear you, Ashley. Thank you very much. Sorry, I missed half of the question.
I think David answered that very nicely. Thank you.
So there's a question here from Alistair Sterling. How do we optimise efforts from NICE, low back pain pathway, MSCC, etc., all the guidelines, with regards to the clinical network and GIRF to minimise duplication of effort? In other words, how do we bring all of these strands of work together in the optimised manner? Perhaps that's you, Mike, first, and then David.
So it's a very timely question. I've deliberately steered clear of mentioning what is the best MSK program because, as those of you at the beginning of the meeting may have seen, it's a bit of a plane flying being put together as we start. In essence, the plan is that all these pathways are ingrained and standardised in each network, so that they implement and incorporate all those things that you refer to, Alistair. So as an example, if you look, there's a work stream for spinal optimization and restoration of services in an NHS improvement at the moment. And that program's called Best MSK. And the plan is that I've learned this. You can say what you think's best in spinal surgery, but unless you talk to the radiologists about it, they'll just kick back and say, well, we didn't agree this. If you don't speak to your primary care side of things and community care and rehab, then they'll be kicked back on any pathway introduced. So the very positive thing about this this program that is literally just taken off is that there'll be people all agreeing across all the aspects that are important from front end to the end, that we all agree that this is the way to do things. The next bit is actually that implementation. So I'd like to think that my real dream, and I'm sure yours, Alistair, was that we can actually have some, everybody singing from the same song sheet without silo working. That's the biggest problem. We've all seen silo working going on for so long, whether it's pain, spinal neurosurgery, orthopedic neurosurgery, it just all needs tying together. And that's the positive thing available, I think.
Thanks, Mike. A question from Ray about talking about learning lessons from medical negligence cases. I suppose this is a question for you, David, as it probably relates to regional spinal networks and how they're going to function. Could you also tell us about funding for regional spinal networks?
Yeah, so obviously the world is changing. So financially, the last year has been difficult because a lot of money has been blocked out because of COVID. But money was released or has been released to every network around the country. So there is money there, which is to the tune of about 150,000 per network for a clinical lead, for managerial support, admin support, of which the admin support to me is partly data support as well. And I have written a draft specification for what a network should look like. I was advised that I can't mandate it, because a lot of this is about regional control and network control, but we can certainly use it, and I'm very happy to share that with anybody who wants it, about how to set up a network. And Mike and I have done a lot of work with this together, certainly around London. And I think my view is there's certain things that networks should discuss, and I believe strongly, and it's not mandated, but we should discuss litigation claims across a network so that we can all learn from each other. because quite often a lot of these claims will work across the network as well. So these sort of things should be mandated as part of your meetings to discuss and learning points and where we can move forward.
Thank you. There's a couple of questions that go well together. So Jeremy Fairbank and Colin Nardi are asking about the registry, and I guess there'd be a good answer from Mike and David, perhaps from two perspectives. So Jeremy's question was non-operative care is very important in spine care and relevant to consent with Montgomery particularly. The BSR currently has no pathway for this, and CPP is really important and needs to be measured. And the second question from Colin is, are there plans for BSR to become mandatory? So I guess the question is do we need to end up with a mandatory registry, and should it include conservative care?
Shall I go for that first?
Yeah.
So, Jeremy, I 100% agree. I think one of the things, again, that I've learned is it's all very well having a really good pathway, but if there's a bit of the pathway you can't actually refer the patient to because it doesn't exist, then the pathway doesn't work. And so in proposing our pathways, where CPPP is part of them, understandably, I've been able to sort of, what's our top 5 asks in terms of priorities? And number one was CPPP and actually the availability of that. Now, one of the interesting things is that I don't think central control has any idea of where CPPP exists or doesn't exist. So what's really important in the gateway process with London is that we're actually mapping things that can only be answered locally by clinicians, which is, where have you got 24/7 MRI? What is your MRI facility out of hours other than that in other non-hub sites? And what is your access to combined physical and psychological rehabilitation programs? What do you actually have out there? And only then, and that's why you have to have these networks, because that's where you get that local feedback. But we are actually going to map that in data, just in a very short self-assessment questionnaire when we have these gateways. And following the data being reviewed by the network trust, we sit down with everybody involved with spine services in a gateway meeting. They're about to start in London. We had to pause for the second wave. So at that point, we can actually sort of say, right, what do we think should be our primary goals in that network? And if it's, look, we don't have access to CPPP in this particular region, then that's where we concentrate the input financially.
I'll just add to that briefly in the fact that, so I think with the thing about synergy and what we all want as well is the fact that, so Mike and I are working very closely together. So the CRG, GIRF, everybody, so it's all coming together, to be honest, under one umbrella. In some ways, the commissioning side of it can be fund things, and then Mike's got the data and the implementation part to some extent, but we're doing it all together. I think CPPP, the problem with CPPP was, the problem with spinal surgery is it crosses non-specialised and specialised, and funding was always a big issue from that point of view. Now we've got ICSs. I think an ICS is about the right size for a CPPP programme rather than an individual commissioning group deciding. So it's much easier to commission the whole pathway. Also, that ICS is a population basis of funding. So you can chuck all your spinal money, pain money, everything into one big pot and say, in your ICS, what do you want to do this? And the BSR is mandated for specialised. It's not for non-specialised. It was part of a BPT. Now, that's sort of been messed up because of COVID funding. But my view is that through the networks, we need the data. So therefore, in your network, you can take a bit of your money to fund your registry, and you collect the data for your network to prove where you want to put your money and where you would need to fund, as Mike said. And then you can get, every network will be slightly different than what they need. But if you've got the data, then you can actually help correct that.
Yeah. Can I just ask both of you what you think? So one of you mentioned in the talk about the Cumberledge report and how she has basically stated that data should be mandatory and that overrides the patient's choice. So this raises the question of whether there's a relevance to revisiting the question we've had over many hours about revisiting Section 251 exemption. Has that given us the power to ask? Basically, Section 251 enables us to not need to require consent from patients. Is it worth revisiting that?
So I think that is certainly coming at the moment, which is good news. In other words, look, we'll give you your operation to the highest possible standards we can, but your part of the deal is we're going to have some data on it because you've had it for free. Now, that's definitely coming. What's also really interesting, so the medical devices safety program, it's just recently been announced that GIRFT is going into NHS England and NHS Improvement from July. So that was literally announced 2 days ago. Now, what's really important that people understand, because I think Sasha was on the call with me the other night, is that there is a clear iron wall between ODEP beyond compliance and GIRFT, if that makes sense. So one of GIRFT's remits is not only to look at implants in terms of their outcomes, but also in terms of their cost effectiveness and how much they cost. There is going to be no influence of GIRFT on that. They're never going to say and which is cheaper, etc. So it's a really good independent thing, and the funding for ODEP beyond compliance has been agreed. Had been under a different organisation which hadn't been working very well for orthopaedics, and that funding is now being carried forward by GIRFT. Most importantly in it is the indemnity for the people who give their time freely to that programme. And you can imagine if an implant performs really badly and they've said it's okay, that's not great. So I think it's going to be really interesting what happens with this programme. The other aspect of this, and I've seen Richard Gullen's note in the chat, is the concept of data entry. I don't know how many of you are aware of Scan for Safety, but that's coming into your trusts everywhere, where your implants are all being scanned in terms of their barcodes. Now, the last thing the BSR has the time, money, or inclination to do is to bring that in, but I would imagine that NHS Digital and NHSX are going to be heavily involved across the entire specialties. I mean, there's a valve, percutaneous valve going in at the moment. They've got no idea whether it works or not. So we are well ahead of the game, and we should commend ourselves and you two guys on the call for actually getting ahead of the game in terms of actually beginning to. We have a registry. A lot of places don't even have a registry. So, and our registry is probably second only to the NJR in the country, I would suggest, or maybe the renal registry. So I think that we will be able to hopefully have things feed into our registry, which will make it less onerous upon us about things like implants. So all of a sudden it gets zapped in there that these are the implants, the codes you use, because the theatre staff are already scanning them. Now that is a big piece of work. So that's what's going to go on for the next few years, I think.
Thanks. Rajat has followed that on, really. He's quite rightly pointed out that one thing making the data entry mandatory, but the follow-up data is the bit that we're lacking. So PROMs, PREMs, complications. How do you see us improving that with a funding and a mechanistic perspective?
I think it's always going to be difficult. You're never going to get everything that you want. I think I very much put through. So the new service specification for spinal services was published yesterday, and that very much puts an onus on clinical networks, puts an onus on data and on the registry. And I would expect that every ICS through that mechanism should have somebody who can be responsible for that data. Now, whether it's at trust level or whether it's at ICS level, that's for each area to sort out. But we know that, so we've been told that from a new model of care with regards to NHS England, that there's going to be a lot more focus on PROMs and PREMs, and all the service specs are going to have to be updated again to reflect that. And if they want that, then they need the data, so they're going to have to fund the data. So we're going to have to utilise that as a mechanism to do it.
Can I just ask the final question, because I think we're going to have to bring the session to a close in a minute. How did we get, when we sort of set up the regional spinal networks, did we get the distribution right for the, do they correlate very well with the ISCs, or are we miles away?
So the ICS, I think in some areas they do, in other areas they don't. I think the problem with ICS is even some of them are now changing again. So the local authorities want them back to them, not to what actually exists clinically. So they don't perfectly match, but there is mechanisms where one ICS can take the lead role and help another ICS. You can like you do with CCGs, where one commissions another. So we can do lead commissioning from that point of view. It's not an issue.
So we're going to keep our network model in terms of the networks as we designed them, yeah.
With maybe one exception, is that the London South West network needs to stop at the borders of London.
Okay. Great. Well, I think that brings us to 11:30. So thank you very much to all the speakers, and very nice to have an update every year as to what's going on. Lots of people, well, a few people doing a lot of hard work, and I think there's a lot of people in the background helping those few people. So thank you very much. Thanks to all the speakers.
Thanks all.
Thanks very much. Cheers.